I'm Dr. Fiona Lovely, and this is the Not Your Mother's Menopause podcast. I'm taking the taboos of menopause and perimenopause and bringing light to the dark. No bullshit, no shame. It's time for us to gain a new paradigm in female health, out with the old and in with the new, and I'm bringing fresh perspectives from someone in the arena. I've been practicing women's health for nearly 20 years, and I'm spilling the tea on what it means to live at midlife, knowing that the best is yet to come. I'm sharing my Gen X approach to living through this transition. Sassy, a bit sweary, and always honest. Tactical tips and instantly usable information is my aim. I hope to make you laugh and that you learn something new that helps you embrace the change. Together, we bring power to the peri. Onward to the podcast. This is the Not Your Mother's Menopause podcast, and I'm Dr. Fiona Lovely. Today, allow me to introduce Dr. Shelly Latte-Naor. She is a board-certified internist, integrative medicine physician, and menopause care specialist. She focuses on mind-body medicine and non-pharmacologic practices to support cancer patients during treatment and survivorship. Dr. Latte-Naor advises patients on evidence-based complementary therapies that optimize treatment adherence, minimize side effects, and enhance quality of life. Her work centers on alleviating menopausal symptoms in cancer survivors using a proactive, patient-centered approach grounded in evidence-based midlife women's health. She has over a decade of practice in mindfulness meditation. Dr. Latte-Naor is trained to teach mindfulness-based stress reduction and has extensive training in hypnotherapy with the Society for Clinical and Experimental Hypnosis. She also specializes in behavioral sleep medicine, using an integrative approach to cognitive behavioral therapy for insomnia. Most recently, Dr. Latte-Naor served as the director of the Mind-Body Medicine program at Memorial Sloan Kettering Cancer Center and held academic roles at Weill Cornell Medical College. Her research has focused on non-pharmacologic symptom management, particularly addressing menopausal symptoms in cancer survivors, and mindfulness-based interventions for cancer-related pain. Dr. Latte-Naor has authored several articles and book chapters on integrative medicine in oncology, including a chapter on integrative oncology in the textbook of Cancer Supportive Care and Survivorship. Currently, she serves as a lead physician for the early preventative health startup Aura, collaborates with the National Women's Health Platform MIDI, and sees patients in private practice across New York, New Jersey, and Pennsylvania. This is my favorite part of this show, other than meeting you guys, is getting to meet these amazing women that are really moving the needle when it comes to what's happening in midlife women's healthcare and the issues around that, whether it's menopausal care or, in the case of Dr. Latte-Naor, it's taking care of women who are experiencing menopausal symptoms, perhaps because of the side effects of the treatment of breast cancer. Now, she, as I said, is an internist and an integrative medicine physician, and we had a comprehensive conversation talking about the issues around treatment of hormonal-based concerns or menopause-related concerns with breast cancer treatment. And, what a beautiful conversation to have. As Shelly says to me, there's so much shame around this for women, and we have to navigate that ourselves. We have to find that space where we are supporting our own physical and psychological health. But the truth is, it's such a big and scary diagnosis that we don't necessarily or are encouraged to take a moment of pause to try to figure out what we feel is the next best step forward. So if you've wanted to know about how it is women who have had a cancer diagnosis in the past or are currently experiencing cancer, how we can manage menopausal symptoms that are often the result of either the surgery related to the treatment, to the diagnosis of breast cancer, or the treatments themselves that throw women into menopause. This is the conversation for you. Shelly talks about the self-care burden and the shame of those cancer diagnoses. And if you're one of the women that has asked the question about tamoxifen and HRT, she answers it for us in the most beautiful way. We talk about sleep, we talk about stress management, we talk about how a lot of the symptoms of menopause and perimenopause can overlap with the symptoms of treatment of cancers. And for example, brain fog is what she gives us. She also tells me that treatment related menopause, so women that are put into menopause because of surgery or treatment, like is involved with cancer treatments, tend to have more severe symptoms. And we have a conversation about how there's such shame around even saying, I need more help. I'm having these other symptoms over here because of the treatment. How can I get the help? So share this episode with whoever you know in your life that needs to have an open and honest conversation about what is happening with women's bodies with a cancer diagnosis or even just a menopause diagnosis. I know we're not diagnosing menopause. That's like diagnosing puberty. Like, come on, we're not doing that. But anyways, Shelly and I have a great conversation. Please go find out more about her on her website, which is Shelly Latte-Naor, MD.com. And she's also on Instagram and TikTok. You're in for a great conversation today. Without further ado, here's my conversation with Dr. Shelly Latte-Naor. Right then, listeners, it's spring. The days are getting longer, and if you're anything like me, you're feeling that little nudge to shake off the winter cobwebs. And just like we might be tackling the clutter at home and washing walls and doing what my grandmother would have called spring cleaning, it's a brilliant time to think about a bit of spring cleaning for our bodies too. Now, hands up. Who of you has a whole shelf dedicated to various supplements? Me too. Well, these days I've simplified things brilliantly with AG1. It's my little daily habit, and honestly, it helps me feel so much more energized as I embrace these brighter mornings. It's just one simple drink to support your digestion, your energy levels, and even our skin from the inside out. And because we're all busy bees, especially as we get out and about more in this lovely spring weather, the AG1 travel packs are an absolute godsend for staying consistent on those weekend getaways or busy work days. Now, when it comes to our health, we want something we can really trust, and that's why I choose AG1. With science-backed ingredients and real benefits I can feel, AG1 makes it easy to support overall wellness every day, and that's why I've been partnering with AG1 for so long. AG1 is offering new subscribers a free $76 gift when you sign up. You'll get a welcome kit, a bottle of D3K2, and 5 free travel packs in your first box. So make sure to check out drinkag1.com/Fiona Lovely to get this offer. That's drinkag1.com/Fiona Lovely to start your spring on a healthier note. I'm delighted to have AG1 as a sponsor of the podcast. Remember, it's a foundational nutrition supplement, and I drink my AG1 every day to support my immune health. It's all part of feeling our best during this fabulous next chapter. I'm Dr. Fiona Lovely, and this is the Not Your Mother's Menopause podcast. And I'm thrilled to have a guest today that I can't wait to talk to, Dr. Shelly Latte-Naor. Welcome to the show.
Thank you. Thank you so much for having me. I'm excited to be here.
I'm excited to have you. I was thrilled to get your email. I mean, I could just feel the heart in it. And, it's funny, I get approached about guests wanting to come on the show all the time. And most of the time, we just don't have enough shows to actually. But when yours came in, I'm like, yep, I sent it right off to my assistant. We were going to respond to this one right away. So thank you so much for reaching out. And I understand you have listened to episodes of the show.
Yes, I have.
Wonderful.
With joy.
Thank you. Thank you. Well, it's a passion of mine to do still 10 years later. Here I am still doing it. So you're an internist and an integrative medicine physician,
Correct.
and you practice in the United States, yes?
Yes.
Very good. And your focus really um, is really about helping women with menopausal symptoms when they have either are experiencing cancer or are cancer survivors. Can you talk about that, please?
Yes, absolutely. So, I'm just a regular internist, like the rest of us. I haven't gotten any training in menopause or perimenopause. And so I'm a little bit of a reluctant menopause specialist because this is something that in a way fell into my lap rather than me seeking it out. So for the last 8 years, I've been a faculty member at Memorial Sloan Kettering Cancer Center in New York City, and I was part of the integrative medicine faculty. So I advised patients on the evidence-based use of complementary therapy across their cancer journey, how to support themselves with non-pharmacologic treatments. And so what I noticed that my clinic was about 80% women, and the majority of them were breast cancer survivors and gynecological cancer survivors. And so I saw these patterns of symptoms that came over and over again. And eventually it became clear to me that this is a menopausal spectrum experience that they're going through either because of the treatment, right? Either because of estrogen targeting treatment, or because they've been through chemotherapy or radiation therapy or surgical menopause. And so, in a way, that's these patterns formed, and even sort of the slow internist that I am, I eventually said, oh my gosh, this is this whole demographic of women that have these menopausal experience that are very poorly addressed because it drowns in the shadow of the big C. So these symptoms are not regarded as as severe or as impactful as they sometimes are. And treatment options are very limited. So it's sort of a perfect storm where also many of the symptoms that are sequelae from the cancer treatment overlap with symptoms of perimenopause or menopause.
Mhm.
As for example, brain fog overlaps with chemo brain, right? So it compounds itself and just results in a situation where people have really severe symptoms that are under addressed. And sometimes that's even worsened by the fact that people almost feel shame for bringing it up, right? So, they cured my cancer. I'm not going to talk about that I don't have any desire for sex. So that's sort of the environment we're in. There's shame, there's under treatment, there's in a way a little bit of a disregard sometimes to these symptoms. Just becomes less of a priority in the whole landscape of cancer survivorship often. But for
Mhm.
the patient, it's high priority because it affects them every single day. And as you know, there's a whole spectrum of symptoms. It's not, just the hot flashes that have been shown to be more severe, more frequent in patients that have treatment-related menopause. But it's also then, yeah, I mentioned chemo brain overlapping with, the brain changes and cognitive changes of midlife, the sleep disorders, right? There's a really high prevalence of sleep disorders in cancer survivors, period. But we also know what happens to sleep in midlife women, right? So all these
Yes.
things converge to be even more impactful, and yet receive little attention. So that's what I saw in my clinic, and then that's what sort of propelled me on that path to becoming Menopause Society certified and turning more towards, how to treat and support these women.
Yes, absolutely. I want to pick up a thread you just said there. Um, you said cancer, people experiencing cancer have sleep disruptions. Can you talk about that a little bit?
Yeah, so there are various pieces to this. First of all, just in terms of observational studies, we see that the prevalence of sleep disorders can be estimated around 60% in cancer survivors. Now, we know that it's somewhere similar in that ballpark as well in midlife women. And this is just all sleep-related concerns. In cancer survivors, this is often prompted by, of course, the psychosocial stress of the
Yes.
diagnosis and the treatment,
Mhm.
but this can also be influenced by some of the treatments themselves, right? Many patients get along their chemotherapy, for example, higher doses of steroids. They can absolutely kill your sleep.
Mhm.
And then, um, there are other factors that can be of influence both in midlife as well as in cancer survivorship. For example, weight redistribution, weight gain, right? We often
Yes.
think about weight loss when we think about chemotherapy, but the reality is breast cancer treatment, for example, is more often associated with weight gain, right?
Really?
Yeah.
Wow.
And so many women gain weight. And then there's also all the metabolic changes that come both with going through chemotherapy as well as losing some of these hormones, which are, a change in body composition, accumulation of body fat, loss of muscle, and that can be quite accelerated when going through chemotherapy. And then the metabolic changes that come with that, right? So a change in lipid profile, sometimes insulin sensitivity changes, right? Insulin resistance emerges. And all of these things can sort of also contribute to some of the performance during the day, right? So
Mm-hmm.
energy, fatigue, cognition, and of course, mood. And that in turn can also influence sleep. So it's all sort of clustered again, it all converges into this big knot of different symptoms that sort of worsen each other sometimes.
And you're working to pull those apart and say, are we treating this menopausally? Are we treating this from an oncological point of view? Like, how are you deciding where to go?
Well, it really depends on where the patient is in their course, right? If they just came out of chemotherapy, then there might be issues to be addressed that are related to the chemotherapy. But overall, a lot of what I do really addresses both, right? These really proactive preventative health and looking at stress management, sleep optimization, and then targeting the symptoms specifically and giving patients the whole range
Mm.
of available treatment options from prescription medications to non-hormonal or non-pharmacologic treatments to even sometimes the use of supplements and other non-pharmacologic treatments like
Mhm.
acupuncture when appropriate.
Hmm. Hmm. I love to hear you talk about sleep because we, as a society, have a tendency to go, well, yeah, okay, they say I need to have more sleep. It almost comes off as trite, but it's actually one of the most important and it's a keystone of health. And so it's easy for us to just go, well, productivity is more important than my own sleep. So I'm happy to talk about this subject. It's a really, really important one.
It really is important. I see women often, especially breast cancer survivors, there's quite a bit of what I call self-care burden, when people
Mm.
really want to invest in their health. Of course, they had this scary diagnosis and they often want to support themselves as best they can through their lifestyle choices. But
Mhm.
that can also turn into a big stressor when, every meal feels like it's really high stakes, what you're going to put into your mouth, what you're going to put on your plate. Every maybe skipped workout feels like, oh my gosh, am I, how is that affecting my health? So
Wow.
everything, all these
Yeah.
health related decisions feel a little bit more high stake often in survivorship. And it turns sometimes self-care into like the second job. But I can't tell you how many patients I see that will say that they're starting their day with juicing and they really try to get a meditation and a workout in and go to acupuncture and they also have to do their lymph therapy and it just becomes
Mhm.
a lot and it becomes a burden that actually adds stress rather than supports people with stress
Sure.
and all of that of course can influence sleep.
So, you're talking about some pretty important psychosocial things here that I think get left out of the conversation around, first of all, menopause, but certainly cancer and get the experience of cancer. So, how best to get support? How do women get support around these things for, as you talked about, the burden of self-care, the shame that comes with a cancer diagnosis and treatment? Let's talk about that, please.
Yeah, absolutely. I don't think there is a simple answer to this. I think that we're seeing all this data emerge about how survivorship is something that we're not doing very well. Right, the cancer centers discharge patients sort of earlier and earlier. The survivorship programs are often very limited. People get discharged out into the world of primary care, which we know is a system that we're also
Problematic,
not doing
yes.
very well.
Also, yep.
And so many of these survivors are not captured very well in the system. And a lot of the symptoms that are lingering may not be optimally addressed and acknowledged. And so I don't think there's a simple answer for this. And I don't think I will solve that problem. I think this is a systemic problem. I think that as you know, we're every year we have a growing survivorship population, which means that people are often, most women are diagnosed in early stage breast cancer. They go on to have a long life,
Hmm.
but with these symptoms, some of
Hmm.
them will carry some of these symptoms with them. So
Hmm.
we really have to take charge of that part of survivorship care a little bit better, a lot
Hmm.
better.
Hmm.
So I
Hmm.
don't think there's a simple answer to this, but what I tell patients often that, self-care starts with just putting a hand on your heart and asking yourself, how do I care for myself? What do I need today? Right?
Mm.
So you sort of need to try a triage for yourself what your need is and what would be the biggest support. It doesn't all have to fit into one day. And we have to make a plan often of how to address issues first. And you said it, sleep is very foundational, right? If we don't sleep well, it's very unlikely that we'll meet our dietary goals, our exercise goals, we'll address some of the cognitive changes that we might experience, right? It's all of these things are really built on a restorative, healthy sleep. And so I think that's very, very foundational.
Mm. Yes, absolutely. So many things I want to, where places I want to go with this conversation, but I have to ask the question because I get asked this a lot and I'm never really sure the answer. Tamoxifen is sort of one of the more well-known breast cancer treatments. And one of the
Mhm.
questions I get asked by my own patients is, can women who are either currently on tamoxifen or have recently been on tamoxifen or now off it, can they take HRT for treatment of menopause symptoms?
Great, great question. So I think the conversation around hormone replacement therapy or menopausal hormone therapy in breast cancer survivors is slowly shifting. And there is a lot of expert opinion that are trying to loosen up some of the dogma we see about estrogen in particular, especially in hormone sensitive conditions like breast cancer. That being said, people that are on tamoxifen have been prescribed tamoxifen because they have an estrogen receptor positive breast cancer. And tamoxifen is an important part of uh, reducing recurrence risk. We know it reduces recurrence risk. And so it doesn't make sense to be both on tamoxifen and hormone replacement therapy with a little disclaimer that yes, you can do local vaginal estrogen for the
Mhm.
most part. And you probably should, right? So
Mhm.
a lot of women that are on tamoxifen do experience changes in the genitourinary system, and that sometimes can be really well addressed with local vaginal estrogen. But systemic estrogen is a little bit of a different conversation. Now, people that have had a remote cancer that is long past, and we may want to look at the cancer risk and discuss with the oncologist if symptoms are really impairing quality of life. It's a risk benefit
Yes.
discussion that we have to have with a patient, right? And today there are many different options beyond just the traditional menopausal hormone therapy, um, of which we really don't have evidence that they increase the risk of breast cancer.
Yes. Say
And
that again, please. Say it
so
again.
So we don't have evidence that some of the contemporary treatments for hot flashes or menopausal hormone therapy increase the risk of breast cancer beyond your already existing risk, right? We have boobs, we have a risk for breast
Yeah.
cancer.
Yeah.
That the risk may vary by genetics and by other factors, exposures, and so on. But we don't have good evidence. We don't have firm evidence that the contemporary, most commonly prescribed menopausal hormone therapy increases the risk for breast cancer or breast cancer recurrence.
Yes.
So there's a lot of unknowns around that. There's a lot of need for more research, but at this point, we should really have a conversation that involves risks and benefits with patients.
Yes. Yes, absolutely. When I think about some of the patients that I've talked to over the years about this, they say, like you said, it's a remote cancer situation where it's been many years since they had it. They may still be taking tamoxifan's part of the SERM category of yeah,
Yes.
okay, so that's what I thought. So that have been taking that particular therapy and maybe have recently stopped taking it. And they're saying the symptoms of the menopause are worse than thinking about potentially having breast cancer again, whatever benefit I might be getting from continuing to take the SERM medication or whatever else is associated with the cancer. And I think, like you said, it's that risk benefit thing. It's, which you get to choose. But I think quite often women don't know enough to advocate for themselves here, or they don't have a doctor that's representing well the options they have. And I
Yeah.
love what you said about this contemporary conversation is really changing, which is it's about time, Shelley, right? As you and I know, it's about time. So I'm totally here for it.
Yeah, yeah, absolutely. And it's important to say that there are a lot of different options to support patients that may be non-hormonal as well, right? So I think that that's also, I have a lot of patients that have a lot of fear around estrogen, which, we know we're now understanding is not really warranted. It's not something that feeds the cancer, like I sometimes hear. It's not something that has caused the breast cancer, right? It's just that these cancer cells exhibit this receptor and it may perpetuate the growth
Yes.
of existing breast cancer. And it's true that we're concerned about hormone receptor positive breast cancer and late recurrence.
Mm.
Unlike triple negative breast cancer, where most of the recurrences happen within the first 5 years, um, we see late recurrences in estrogen receptor positive breast cancer. And so the oncologist rightfully is very, very cautious around exposing patients to things that might, even if there is a really tiny might,
Mhm.
that might increase that risk, right? So it is a very nuanced conversation. And today we
Yes.
also have ways to estimate risk. What is our risk for breast cancer, right? There are tools, questionnaires online, as I'm sure you
Mhm.
know, that
Mhm.
all of us can take.
For anybody listening, which is your favorite of those tools? Please
The
share.
Tyler Kruzik. I can send, we can probably put the link
That's
in the,
perfect. Thank you.
yeah, because I think everyone should know that and do that at some point.
Yes, yes. Thank you for sharing that. So you talk about the non-hormonal or non-pharmacological options
Yeah.
for treatment. Can we talk about that, please?
Absolutely, yeah. So, the Menopause Society has, I want to say in 2023 or 2022,
Recently,
released the
yes.
last, yeah,
Yeah.
released the last position statement on non-hormonal treatments for vasomotor symptoms. And here I have to put again a quick disclaimer in that when we're talking about menopausal hormone therapy, we're often treating more than hot flashes. Now, when we're talking about non-hormonal treatments, these are really, for the most part, benefiting hot flashes, right? So I'm gonna tease them apart a little bit more, but that's
Please.
sort of the complexity of not giving hormones that systemically work on all these different tissues and organs and symptoms that we may have. Here we're giving a treatment that is intended to lower hot flashes. Sometimes it addresses other things too, but the care with non-hormonal options is a little bit more clustered. We might have to support sleep and hot flashes and other things separately. So that is one thing to keep in mind. Now, when we're looking at the physician statement, there are a couple of categories of medications that are most commonly used. These are SSRIs and SNRIs, so medications that are usually prescribed for anxiety and depression, that are probably most commonly used in this setting. And some patients, and so what I have to say about this is that they're usually prescribed at much lower doses than we would for anxiety and depression, and they might be effective at lower doses to treat the hot flashes, which means that at lower doses, there's also a lower risk for some of these adverse effects. And if it's not the right thing, it's also not as lengthy or difficult to titrate somebody off the medication, right? So that is something that I tell people often. And, if there is underlying anxiety and depression that needs some support, which is not rare in survivorship, that can also be an added benefit, right? But that is one thing that can be treating hot flashes in the survivorship setting. Other medications include gabapentin, and you're noticing these are repurposed medications, right? These are not dedicated medications. These were sort of by mistake noticed to also treat hot flashes, but they're used for other things. So gabapentin is usually used for neuropathic pain, for example. And it's quite sedative. So it's actually quite a good sleeping aid. So some women in whom I'm seeing a lot of trouble maintaining sleep or initiating sleep and hot flashes, that might be a good option to try. Another medication is oxybutynin, which is an anticholinergic that is used for overactive bladder. But, oops, we also discovered it treats hot flashes. And that is quite good when people have, a lot of sweating. It's a little bit drying the medication. So when people have a lot of sweating, that is something that can be used, and people do really well with it as well. So all of these medications have risks and benefits that need to be teased apart, and they sometimes have contraindications. But these are some of the most commonly used options. There's also a newer medication that is called Veozah or fezolinetant, and that is a more targeted medication that targets the mechanism that was more recently probably discovered of, centrally where our temperature regulation system is affected by the withdrawal from estrogen. And it is a little bit more specific. I'll say a lot more specific than these other medications. It's really for the treatment of hot flashes. And that is also something that's available.
Protein and healthy muscle are the organ of longevity. Do you struggle to put on muscle, lose weight, or get enough protein each day? It's a common concern, but there's help. I prefer Kion Aminos to get my daily essential amino acids. Kion Aminos ensures you're getting the essential amino acids from protein your body needs to rebuild muscle, recovery, keep energetic, and be strong. Kion Aminos is a clean source, transparent formula that gets mixed into water and tastes good. It's suitable for all diets, is gluten-free and dairy-free. It helps me feel full and hydrated and ready to go. I feel strong and I recover from activity quicker when my protein tank is full. Would you like to get better protein intake and supplement with Kion Aminos? Please go to getkion.com/lovely, where Kion is offering 20% off for listeners of the show. There's a risk-free 60-day money-back guarantee. That's getkion.com/lovely. And I'll drop the link in the show notes. Thanks, Kion. Hey guys, Dr. Lovely here again. Sorry to butt in while you're listening to this episode. But in case you don't know, I send out an awesome newsletter every 2 weeks. It's called Fiona's Friday Favorites, and I'm getting lots of great feedback about it. I pack it full of the latest and greatest in menopause and perimenopause information, whether it's research or treatment options or my favorite supplement or my favorite yoga pose or recipe or book or podcast. of that 2 week period. People are loving it. So go to drlovely.com. That's DRLOVELY.com. And right at the top where it says shift here, enter your name and your email address, and we'll be sure to add you to the list of Fiona's Friday favorites. Thanks for listening. And what about non-pharmacological options? By the way, I just want to say, I really became aware of the conversation around the symptoms of menopause that come up alongside treatment of breast cancer from Avram Blooming and, of course, his book called Estrogen Matters.
Yes.
And I remember seeing him interviewed somewhere quite probably 5 years ago now, where he said his own personal story was that he's an oncologist, and his wife was going through breast cancer treatment, and she
Yeah.
was having such terrible symptoms that he thought, well, I can do something about this. Meanwhile, her oncologists were just sort of outright saying, no, we can't do anything about it. So he went about doing the literature review and compiled it in this book that I think is very, very useful.
Yeah,
And
it's fantastic.
yeah, good, good, good. I was hoping you were going to say that. And if you weren't, we were going to talk about it. So it's all
No,
good.
it's a great book. I really recommend it regularly to my
Me too.
breast cancer patients, so that there's a little bit of a loss of this fear of exposure to this hormone, and
Yes.
really treating the available literature with a lot more nuance and depth.
Yeah, and I think just to make it sort of a blunt statement about it, we have estrogen in high levels cycling all the time through our
Yeah.
bodies from the
Yes.
time we start our periods until when our periods stop.
Yeah.
And so if estrogen caused breast cancer, we'd all be running around with breast cancer all the time, right? Now, there's some nuances to that, but I think, generally speaking, that's a good place to start talking about it.
Yeah. Yeah. So a couple of things that challenge this notion of
Please.
estrogen being dangerous is the fact that most breast cancers get diagnosed in the postmenopausal phase where we actually don't have all that much estrogen, right?
No,
So
that's
that
right.
really challenges that notion. In addition to that, when we're looking at the data of people that have repeated high exposures to estrogen, what is that? That's pregnancy. Pregnancy comes with a very high exposure to estrogen.
Yes.
And so what we're learning is that people that have been through pregnancy and breastfeeding, that's actually protective
Yes.
against breast cancer, especially when it happens earlier in life. And then people that have been through a lot of pregnancies throughout their lives should be at higher risk, right? They had these repeated exposures throughout their lifetime. And yet we're learning that these actually have also lower risk for breast cancer.
Yes.
And then we're also have now good data that women that have been diagnosed with breast cancer early, they are allowed in quotation marks, to come off their treatment, of their anti-estrogen treatment, to become pregnant and then
Okay.
resume their treatment. And we know that that doesn't increase their risk for recurrence.
Yes.
Right? So we have data that this high exposure to estrogen in somebody that has a higher risk, right, because they had breast cancer, is not associated with a higher risk of recurrence. So, these are some of the things that may challenge our notion that estrogen is this
Yes.
driver of estrogen, this initiator of this malignancy,
Mm.
which it probably isn't. It may contribute in some ways, but it's not something that we have to be fearful of,
Mm-hmm.
especially in light of the many protective factors that it brings.
Mm-hmm. Mm-hmm. We're at a really interesting time to be alive because I think about, when you're talking about having the conversations that this kind of thing would require for women to have with their doctors not that long ago, meaning our mothers, our grandmothers, would not have asked the questions because it's indelicate, it's not ladylike, it's not polite to have the conversation about, how do I protect my breasts? My vagina's dry and I don't feel like having sex. Like,
Yeah.
we women were not talking about this because it was not considered okay to discuss it. And here we are
Yes.
in this place where women are finally just saying it's not okay that I
Yeah.
have no lubrication and pain hurts.
Yeah.
Help me.
Yeah. Absolutely.
Really.
Absolutely. So I'm not saying it's we have a way to go with that,
True.
especially in cancer survivorship.
Sure.
But yeah, absolutely. It's so I recently sat in a coffee shop here in Brooklyn, and it's a small, cozy coffee shop. And next to me sit two women that apparently had their kids in the same school or same class, and they had this conversation. All of a sudden, they were sharing perimenopausal menopause symptoms, and I couldn't help but overhear, right? And so soon thereafter, one woman showed the other that she was wearing an estrogen patch, and so they discussed where they get that prescribed, and they
Yes.
exchanged information about providers, and eventually I disclosed I disclosed that
Yes.
I'm sorry, I'm overhearing this, and this is really really great for me to hear,
Yes.
but um, but yeah, it was very, it's just a real change in atmosphere and environment. When we're thinking just a generation ago, menopause was not only not talked about, it was also associated with shame. People wouldn't even, yet, never mind not disclosing it to your physician, but amongst each other, women would also not necessarily
Yeah.
speak about it. And culturally, it was drawn more into this comedy side, right? When we're thinking about how women were depicted in movies or TV shows, fanning
Oh,
themselves, opening the window. It was all, was there something a little bit funny about it, or it
yes.
was depicted as something almost comic, and definitely not taken seriously from all
Yes.
sides of society or medicine. And so I think that that's the pendulum is gradually
Yes.
swinging to.
Is coming back. Yes.
Yeah.
Well, or we're going to a place where we really need it to go. I was having a conversation recently with a friend who has a family member going through cancer, and
Mhm.
she had mentioned that there had been a cancer appointment, a check-in. I said, can I ask, did it go okay? Just being a good friend. And I said, if that's prying, don't have to answer any details. Just, basically, how can I support you? And she said, no, everything went well, and gave me a bunch of details. And she said, we have to talk about these things. We
Yeah.
have to talk about these things. And she said, because otherwise it's like a secret that just, and we know enough now about psychology that is a recipe for more dis-ease to breed.
Yeah.
And when I was talking to my friend about this, I said to her, I said, you know what, this is not dissimilar to what's happening with menopause right now. Is
Mhm.
I if we've what's the statistic, Shelley? Is it 1 in 2 or 1 in 3 of us will experience cancer in our lifetime?
Oh, I don't know that like the
That's okay.
general
That
statistics, but
it's like the number two cause of death in the United States and North America. Yes,
I believe so.
heart
Yeah.
disease number one,
Heart
cancer
disease
number
number
two.
one. Yeah.
Yeah,
Mhm.
and yeah. So, anyways, I'll put that thought aside and come back to it. This is really many, many, many of us will experience, let's say it's
Yeah.
half or a third of
Mm.
us will experience cancer. Why don't we hear more about it?
Yeah. Yeah.
That shame thing. Let's talk about that, please.
Yeah, absolutely. Yeah, I think it's very difficult to navigate because it's also something so incredibly scary for many. And so in menopause, it might be also a scary experience, especially because there's little guidance, little preparation. But here, women are often confronted, or anyone with a cancer diagnosis, really confronted with the idea of mortality
Mm,
and with a life-altering treatment,
mm,
is confronted with, all these questions around identity and maybe a sense of betrayal of the body, right? So a loss of trust often goes with that, right? And so it's really quite complex. And many patients still choose to not disclose, even to their family members or their kids. I'm the last to judge, but I'm always concerned about their support system if they're not disclosing, right? But I think it's a very complex situation. Everyone has to titrate that for themselves. I think everyone has a different need and a different idea of what support looks like. For
Mhm.
some people, it's a lot of community, right? A lot of distraction, a lot of action, right? And so for some people, it's actually being shielded from that. And so everyone has to titrate that for themselves and even, become aware of their needs. Otherwise, everyone else will take over. Just becoming aware. That's what I'm encouraging patients to do. Just becoming aware what supports you best.
We talk about personalized medicine, about bioindividuality, and what you're saying is that that applies to our psychology as well.
Yes, of course.
That's
Yes.
so interesting. We need to titrate. Those are the words you used, and to be shielded from the community sometimes is the answer. I I don't know myself because I have not experienced it, but I'm pretty sure I would want all the people.
Mhm.
Right? That would be me. My husband, on the other hand, none of the people except
Yeah.
me, right? So
Yeah.
I can see what you're talking about there. You also said the words, this is what I wrote down: identity, mortality, and loss of trust.
Yeah.
Whew, this is
Yeah.
huge
Yeah. Yeah.
and has the ability to affect the rest of our lives. So if a woman is experiencing this in her 40s, 50s, or 60s, she still has a sizable chunk of her life left to live. That these the experience of the cancer diagnosis can really make a huge difference in how she looks at herself and how she interacts with her people in the world.
Yeah, yeah. Not to mention that sometimes the treatment comes with a loss of fertility, with a loss of body parts, with a change in the appearance, right? Which often exacerbates this question of identity, right? And womanhood. And so these are very difficult topics to navigate when, all the stress and anxiety of the cancer treatment is superimposed, right? While these things come up, people have to go through treatment and deal with a lot of physical symptoms sometimes, and a lot of logistics, a lot of financial toxicity, right? It's something really, really stressful. And what happens is that often as people get diagnosed and treated, people go into this battle mode. I have a battle, I have my chemo schedule, I have my radiation schedule. And that period of time, often people do quite well, right? They feel like energized by the fact that they have something to do every single week, and they have something actionable to go against that scary diagnosis. Now, once treatment ends and people fall out of, in quotation mark, fall out of care, right? They don't have this constant contact with their care team anymore. They are sort of released back into the world, into their old life. And the surroundings they just want to toast and celebrate and ring the bell,
Hmm.
while they're now starting to metabolize these questions about identity and loss and grief. And so there's sometimes a really stark dissonance between the supportive system that, by the way, diminishes, right? Once you ring the bell, because everyone just wants to be happy with you and for you. It's not something malicious. It's just a lack of understanding of some of the dynamics that ensue once people end their acute treatment, their active treatment, and go into survivorship to start to deal with what for many is quite traumatic, right?
Yes.
And so often what we see is some of these psychological, the metabolization of some of the psychological impact of the cancer happens in survivorship rather than during active treatment.
Oh, that's a whole other episode all by itself. So there's a woman listening. I'm sure, lots of women listening to you and I talk right now.
Mhm.
How does a woman go about if she's in that phase where she's in the survivorship, she's in the I don't think I've yet metabolized, as you put it, the
Mhm.
trauma of going through that experience?
Mhm.
What should she be looking for? How should she reach out to get support? Is there a place, a practitioner, a group of practitioners? Please share your experience and knowledge with us on that.
Yeah, absolutely. So I think the very first thing is to really validate and normalize that experience, right? People are often shocked, they have this expectation, I should be so happy. And yet, no, you've been through something so stressful, and you haven't stopped to take inventory of what's happening in your life. And you're now expected to go back to your job, to your kids, to your responsibilities. That's a lot. And so, first of all, I think we should prepare women for that a little bit more, right? This is what is happening for many, many, many,
Mhm.
many after they finish their treatment, right? Which often it's not expected, and that just adds to the anguish, right? And I think also the cares, the surroundings, the family members support system should be educated about that, because then we don't have that dissonance between the patient and the support system. And then I often say, if during treatment you haven't had psychological support, after treatment, seeking out a therapist that has experience with cancer patients,
Mhm.
is gold, right? You need that time, you need that attention to yourself, to metabolize this experience, right? Like all challenges in life, this can be, a seed for tremendous growth as well, right? I don't want to
Mhm.
pink wash anything, but this is something that we want to sit with and have the opportunity to sit with. And again, don't cover all of this in self-care burden, right? And making a job
Yes.
out of, making yourself a perfectly healthy, really start self-care with caring for yourself and really asking yourself what is needed right now. What would be the most, sometimes it's not the yoga class or the acupuncture session. Sometimes it's just having a little bit of time for yourself, or giving yourself just grace and time and journaling. And everyone will need something else, but only you can really establish that for yourself. And I really want to empower women to explore that question for themselves.
Oh, that's so, so important. And a beautiful way to sort of bring this to a point here. So, Dr. Shelly Latte-Naor, where can people find out more about you and your work?
So I have a website, shellylatte-naor.md.com. I'm also on Instagram and TikTok. Pretty unique name, so I should be difficult to find. I see patients in New York City and also in Philadelphia, New Jersey via telemedicine. Yeah, I'd be happy to be in touch with anyone who has questions or wants to connect.
Amazing. Thank you for sharing your expertise and your knowledge with the listeners today. I know I just said this on a recent episode, so my listeners will hear me saying, "Oh, she's going to say it again." But I remember Oprah saying that when she was doing the show and she was with somebody, she would often have these moments where she could feel the people watching. She could feel how it was transformational what she was hearing. And I think you have delivered that level of information to women through the show today. So, again, I thank you so, so much for that. And I must say, the way you use language, you have to put your thoughts in a book. Like the world needs your book right now. I know you're busy, but just so you know, put that off to the side. But
I'll put that on the mental shelf for sure. Yes.
for sure, just these beautiful turns of phrases that you've used today. So I have a couple of questions that I end the show with, Shelly, and I'd like to ask you the practitioner question first, which is, I live in Canada, and Canada has social programs for a number of different different reasons and different things. And one of the things I'm envisioning for my generation and my nieces, my kids, my etc., the generations behind me, is the same way that when we're younger we can take a maternity leave. And I understand the United States is the only wealthy country on the planet that does not have laws around that, which is, I don't even have words for that.
I
But
don't have
anyways, that's
words. Yeah.
right. It just,
Yeah.
there's just no words. Um, So, in asking you this question, what I believe is happening is that we create the energetic pattern of this in the field so it becomes possible, just like the 4-minute mile. So
Mhm.
let's say the listeners in the US, as well as other listeners around the world that have access to things like a maternity leave, let's say we get a menopause leave. Let's say our
Mhm.
government is going to give us a year or 18 months away from work, is going to replace the salary that we lose with that, plus give us a bursary, if you will, where a lump sum of cash where we can use that cash to do whatever we feel will support us best during our whatever phase of menopause or perimenopause we choose. What would you do yourself with that time and that money?
Oh my gosh, I would travel.
Yes. Awesome.
I would mostly travel. And there's so many things to see and to learn, and life is so busy, especially in midlife.
Mhm.
I was a backpacker in my youth, and just getting up in the morning and asking yourself, what do I feel like today? What do I feel like doing? The liberation that comes with that, I think that's just not something we experience in midlife. It's what does my kid's schedule look like? Or, what are my job's responsibilities? These are just this shift in perspective, this U-turn of attention, right? Instead of all the vectors of our attention going outwards, just having it come back in some shape or form, right? For me, it would be travel. For other people, it would be something else. But that's what I
Yes.
would do.
I love it. That's such a good one. And actually, nobody said that one so far. So I love it. That's a new one. Last question I have for you is knowing what you know now, what would you tell your younger self?
I would tell my younger self that it's that I should strength train rather than do obsessive yoga. Nothing against yoga. I'm still a yogi at heart, but I would tell myself strength training early, at least in my 30s, starting to strength train, start to build muscle.
Yes.
That's what I would tell myself. I think that has a tremendous impact on our long-term health.
Yes, a very pragmatic answer. Thank you. Dr. Shelly Latte-Naor, thank you for joining me on the show.
Thank you for having me.
My pleasure. The information and other content provided in this show, or in any linked materials, is not intended and should not be construed as medical advice, nor is the information a substitute for professional medical expertise or treatment. We are doctors, but we aren't your doctor. Seek your doctor's opinion. If you or any other person has a medical concern, you should consult with your healthcare provider or seek other professional medical treatment. Never disregard professional medical advice or delay in seeking it because of something that you have heard in this podcast or in any linked materials. If you think you may have a medical emergency, call your doctor or emergency services immediately. The opinions and views expressed on this page and in this show have no relation to those of any academic, hospital, health practice, or other institution. Thank you.